The presentation to get your views and your inputs, because what we're sharing with you today is really part of an evolving, what we think is a new or revised approach to patient safety, particularly looking at patient safety across the continuum of care. I'm John Dean, I'm Medical Director of NHS Bolton, and Anne Schenk, who's presenting with me, is Director of Service Improvement at Royal Bolton Hospitals Foundation Trust, and the two organisations have been working together on this programme that we're going to share with you. So what we're going to share is our journey so far, and it really is a journey so far in terms of what we think is a new or revised approach to patient safety across the continuum of care. It's part of the Health Foundation's Safer Clinical Systems programme. And we were involved in the first phase of this programme, which was really a co-production phase in trying to develop some new approaches to system safety. And we'll go into more detail in it. We're going to split the workshop into three sections. For the first section, I'm going to describe to you the approach, some of the tools that were used and developed or adapted during the approach, and then we're going to have a break to get your views on whether there is anything different here in this type of approach to patient safety. Then we'll go into more detail on some of the interventions that were developed across the continuum of care. We'll have another break for some discussion on that. And then finally we'll go into the lessons learned and what that might mean for the future, for us, for the programme, and potentially for yourselves. So welcome. But first of all, I'd like to tell you about Darren. Darren was meant to be presenting this symposium with me today, and Darren very sadly died a few weeks ago, very unexpectedly. Darren was a GP, clinical leader, and a patient safety champion. He'd worked with us as a GP and lead for urgent care general practice for a few years, and had very much become a champion for patient safety. And he was very involved in the work that we're presenting and had a major influence on it and on many people. And his legacy will continue with the patient safety work, particularly across the continuum of care. And I'd like to dedicate this session to him and his legacy. So the traditional approach, I will put it to you, for patient safety is that we identify when something has gone wrong and where that problem is, and then try and put it right or stop it from happening again at that point. But maybe we're missing the point. Maybe we're missing the point because actually the reason that has occurred is not because of that point of care there, or that process of care there, but because actually it's happening in a sea of disorder. And that if we're going to improve care and reduce harm in the future, maybe we need to work on calming the storm and being prepared for the next storm or the next change in wind, rather than simply working on where something's gone wrong in that vast sea. Similarly, we spend a significant amount of time and resource investigating serious events that have caused harm, serious and rare events that have caused harm, which by their nature clearly are serious, but also are rare and therefore extremely unlikely to occur again. And yet that's where we put a lot of our energies and efforts. And yes, we get incident reporting about other events which may be costly or damaging or have caused some personal injury or equipment failure, and that's important work. But every day, in every person's work within healthcare, they are taking shortcuts, they are doing workarounds, there is poor practice taking place that they know is happening every day, and that will not be incident reported. They're either doing a workaround that could cause harm, or they're doing rework because something's gone wrong, or maybe they're doing a workaround to prevent something from going wrong because of the chaos of the system. And surely if we can start to capture some of that information about what's happening on a daily basis, then actually we can start to put processes and systems and cultures in place which will start to calm the storm and make the whole system somewhat safer. We don't believe that that will be captured by incident reporting and safety walkarounds. We think it needs a broader approach to patient safety. I'll tell you a little bit about Bolton. Bolton is in the northwest of England, just north of Manchester. We have a population of 280,000 people. This is a map of the town of Bolton. And this is a map of mortality. And the darker areas are where the higher mortality is. And you won't be surprised to know that that's where the deprivation is as well. Around 280,000 people live in Bolton, and some of them are in the poorest groups of people in England, and the poorer areas, those people are expected to live very significantly longer than others. This gap is narrowing a little bit, but there's still a lot of work to be done. So that's the population that we're working with. Bolton has a number of organisations for healthcare. It has one large hospital, Royal Bolton Hospital, and Royal Bolton Hospital has been working on quality improvement using lean methodology and are well into a lean transformation programme with a significant improvement team and an improvement academy to train its workforce, and using a standardised Toyota-based approach to systems improvement. NHS Bolton has a commissioning arm which oversees healthcare for the population, and we were the first triple aim site in the UK with the IHI, and have developed a clinical quality function which I described in a workshop yesterday, and we've used predominantly a coaching approach. Community services are provided by our provider services, and there's a small cohort of staff who work with all teams and leaders on quality improvement and patient safety, and we're about 3 years into a capability building programme, and we use a flexible approach integrating lean and model for improvement and other approaches. In addition, there are over 50 family practices who, again, you'll have seen some of the peer coaching work that's done around disease management presented at this conference. And, of course, patients also get healthcare and dental practices, pharmacies and optometrists. So if we're talking about improving patient safety across the continuum, somehow, we need to learn how to join this up and make it safe wherever and whenever the patient is getting care. Now, we chose for this piece of work to start this journey to look at urgent care, and the reason was that we've been doing significant work in urgent care. Urgent care, of course, is many services, as shown on this slide in our locality, and whilst most urgent care actually takes place in routine general practice, there are over 200,000 attendances outside that for urgent care a year in our borough. So we've been doing some work anyway, using lean approaches, trying to redesign urgent care, and that was one of the reasons why we decided for our system, for looking at patient safety, to look at the urgent care system. So the Safer Clinical Systems programme by the Health Foundation is an important new venture for the Health Foundation. I'm going to just take you back a couple of slides. Sorry about this. I've lost a slide. Okay, never mind. Let's keep going. Sorry about that. Okay. So, the Safer Clinical Systems Programme is an important programme for the Health Foundation that we were lucky enough to be involved in the first phase of. It's particularly looking at whether we can focus on improving system safety for patient safety as opposed to individual interventions as I described earlier. And as I say, for Bolton, what we wanted to focus on was the urgent care pathway. And particularly, we wanted to focus on improving the transfer of clinical information, some work on reducing pressure ulcers, on reducing medication errors, with an overall aim of reducing readmissions. But we chose the urgent care system as one system to start this work in, with the idea that we would hope to learn and adapt our approach to other systems and other parts of the organisation and healthcare system. Also within the Safer Clinical Systems Programme were three other organisations, Lothian, Hereford Hospitals and Plymouth Hospitals, and all of the sites were chosen because they had a history of working with lean methodologies, and part of the approach of the Health Foundation was to see how that could be translated into system working for patient safety. The sites were supported by an expert safety team who were brought together by the University of Warwick and were giving expertise and supporting the whole programme and development. And this was the first phase of the programme, which was very much a co-production, so very much trying to develop tools, approaches and techniques for system safety properties. So as I say, we wanted to work on these areas, joining up, improving information transfer, and of course many of these approaches needed to span a number of services if we were really going to improve patient safety. So we set up a steering group with executive involvement and senior involvement to look across the health economy, and we decided for our population of focus to start with elderly patients who were admitted to hospital out of hours from the GP out of hours service, and then what would happen to them on their future urgent care journey. So we had a steering group, but the real work was done by individual teams, either in their own clinical area or together at the interfaces. The first step was to get a very high-level map of the patient's journey, and this was done in very simple terms. So we looked at where patients came from, went into the hospital environment, and either then were admitted to wards or went to many elderly patients in our system go to what we call Bolton Community Unit, which is a unit for getting multidisciplinary care, largely around a non-medical model for the frail elderly who may need rapid support at home, and try and put that in place. Some of those patients then go to a skilled nursing facility before they would go home with that extra supported care. So that was the high-level patient journey. The practical approach that was taken, supported by the expert team from the Health Foundation, was to start either at the macro system level, the whole system level, and or at the micro system, the clinical team level. Firstly, to map what was happening. Secondly, to assess that critically in terms of where there may be error or potential harm, and then to define what could be done about that. So it's really important that we did that not only at the macro system level and not only at the individual clinical team or microsystem level, but also at the interfaces, at the mesosystem, where these teams come together, because at those points of transfer, that's where the biggest risk is. So having identified that, how do we then change practice and measure the effects of that change practice at each level of the system? So The next stage was to say, OK, we've chosen urgent elderly care, but there's stuff going on across the healthcare system for these patients already. And if we're really going to identify all the stakeholders that need to work together on this, let's brainstorm what stuff is going on. Either that we know there's a problem that nobody's working on, or actually somebody's working on it already. Unless we engage all of those, then we'll either be duplicating or we won't be coordinating the work properly. Having identified the stakeholders and brought them all together, either in clinical teams or people who were supporting clinical teams, the next stage was to do some more formal mapping, and we used this approach, which is swim lane mapping. Some of you may or may not have used this approach. The difference is, the important thing about swim lane mapping is it identifies individuals or individual teams that may be involved in the patient's care and recognises the interrelationship of those in the patient's care. So this was done across the system, but also at the clinical microsystem level. Having identified that patient's journey, we then said, well, where are the potential causes of error, particularly focusing on transfer of information, medication errors, and pressure ulcers, and identify where those problems may be. What this did, this approach, was to get joint ownership of the problem and people to start to realise the interdependency within clinical teams and within the broader system. The second approach, which I think helped some of the cultural change, was using this, which is called a create and detect chart. Because the reality is, if you're looking at patient safety across the healthcare system, very commonly that error will be identified in one part of the system when actually it's been caused or the start of it has been at another part of the system. And unless those are joined up, then we're not going to put it right. So, for example, if a patient arrives in hospital without the information which that receiver in hospital as a clinician requires to treat the patient safely, then that will be identified in hospital, but actually the problem occurred at the point of referral. Similarly, if the patient goes home without adequate information, that's picked up in the general practice, and yet the error has occurred elsewhere. And this is so for multiple issues related to transfer of information, medication and other things. And again, this approach started to help people to understand how they need to cooperate better. There's a long way to go in order to fix these components of the system, but at least it began to get engagement. The next stage was to critically say, well, how risky are these areas of potential triggers for harm, scoring them based on potential frequency and the severity of failure in a classical FMEA type approach. So having done that for the areas that were identified as potential high risk, we then said for each element, and here we have it for clinical information, where are the potential points of error and what is the level of risk at that point. And from that, we identified the high frequency, high severity potential risk areas that we call the 81s. And those will be where we will first focus our improvements. Another really important step in the journey locally as part of this programme was human factors training for the stakeholders. People had heard of human factors training, particularly those involved in improvement, but bringing the clinical teams and leaders together for a greater awareness of this was fundamental in some of the changes that we started to see. And I think many of the interventions that were developed were done in the context of a developing understanding of how human factors influence safe patient care. Of course, measurement of harm is important, and the hospital had been working on using the IHI Global Trigger Tool for some time, and therefore that was an important component. But when that was looked at in terms of potential harm or actual harm to patients, what we found was that the highest cause of harm was actually readmission, not medication error, certainly not pressure ulcers, but readmission. and therefore that became more of a focus of the programme in terms of a high-level measure that we wanted to see moving. The rate of readmissions for Royal Bolton Hospital was there or thereabouts of other trusts across the region, and it possibly slightly higher. But none of us would want to accept the levels of readmission that we have at the moment. So what this diagram shows is the programme of work that was developed during this co-creation phase of safer clinical systems within Bolton. And what I hope you can see on this diagram is a number of clinical microsystems across the health economy that are the patient journey. And at each of those points, there were specific interventions that were being developed, tested and implemented that once established in that unit, the concept was that they would then be spread as appropriate across the patient journey and used at each point of care if appropriate. At the same time, trying to improve communication across the system. We were measuring harm using the global trigger tool in hospital, and we wanted to develop the use of the primary care trigger tool in the same cohort of patients in primary care. But we were unsuccessful in developing that, and we may get on to discuss why later. So I hope here you get the concept of the whole patient journey, interventions at each point with a view of learning, testing, and then spreading those across the patient journey. So I hope what I've shown you so far is the concept, really, the concept of working proactively on patient safety across the system, in this case for this particular population of patients, as we learnt how to do it. So at this point, what I'd like to do is pause and get some of your input, and I'm asking you these two questions. What are your views on the benefits of working on patient safety at the individual microsystem or process level versus working on it at the macro system level and taking a broader view on it? And secondly, what are your views on a statement that at the moment we have predominantly reactive approaches to patient safety and that we need to move more to a proactive approach to patient safety and identifying risk and putting mitigation in place? So I'd like us to get into some discussion on that. Is there anybody that would like to kick that off?
Thank you, John. So I'd just like to go back to question number one and actually think about, in my experience, health is very much driven by understanding the whole system and therefore finding the weak points. So really just the question for you, John, is would you consider it beginning at a macro level to find the flash points and then drilling down into the micro system to find the individual failure modes?
Yes, I think it is, and what we'll come on to describe towards the end is that it is a combination, and we'll get on to describe what we call a zoom-in, zoom-out approach. So you need to be doing, very much both at the same time, and I think any one approach is, in my view, is inadequate. If we just concentrate on the microsystem, we're missing the point because there may be bigger errors that we're recording. If we just look at the big picture, we're not going to get down to the detailed intervention. But very commonly what we see, and what we saw, for example, if you looked at patient falls as an example, there were actually multiple approaches to doing that across the patient journey, and learning and standardising that, obviously with some local adaptation, became much more productive. Any other points? So what do you think? Are we predominantly reactive at the moment? Why? If you think back, you know, to the beginning of risk management, we were much more proactive. Point over here.
I take us back to the talk that we had from the previous leader of the Shell Group, where he said, you know, we're going through a transformation where we're probably at the system level at the moment, but we need to get to the sort of cultural behaviour where what we do becomes everyday and intuitive, and rather than either reactive or proactive. So I think we are very firmly moving away. And what I worry about is if we are just working at the microsystem level, you know, we have a potential to sort of still work in silos and not worry about what's downstream or upstream. And from my position of working as a lead in trying to manage the integration of primary and secondary care, you know, it's very clear to me what is the relevance of bundles in general practice. You know, if and that's rather an extreme way of looking at the patient safety program, but what I'm saying is, you know, if we don't have recognizable key measures which actually have meaning right across the continuum of care, then actually we haven't even got a starter for 10.
Sure.
So I worry that working in silos just produces more difficulties in trying to reconcile the causality of problems, and that we don't have any agreement on key measures. So I think, yes, we are still in a reactive framework rather than it being instinctive or indeed behavioural.
One of the examples that I use in trying to help people to think more across the system in patient safety is to say we're very good now, or can be very good, at reducing ventilator-acquired pneumonias. But most of those patients end up in a critical care area because there have been errors in their care along the journey. And that actually, if we were also working on those errors, we may get greater reductions in mortality and less patients getting into critical care. Any other points people want to make? Okay, but hopefully what we've done is we've stimulated... So, was there a point here? Yeah, thank you very much at the front. Someone will bring the microphone down to you.
Well, I think that the context is different in different countries. I come from Norway, and I work at the big hospital trusts that's organized about half the hospitals in Norway, and we try to make structures that bring people from the different silos or organizations together and to work out pathways for various patients groups, bringing in experiences from each party. And we have hired, I know that in England, for instance, GPs have the local hospitals as their arena too, but that is not so in Norway. So we have put up small part-time positions for GPs in hospitals to work on specific handover problems on the systems manner. And we also have these formal agreements or contracts on what are we to expect from each other, and try to build it as a system of agreements or contracts or service level agreement, if you can call it so. So in some instances, of course, we have to address errors in handovers, and we do so. And the hospitals have all fairly comprehensive quality systems in place, but they are not accessible from the outside. So we have to make some sort of putting handover problems into that. But on the other side of the coin is to make good systems so that every party knows what the other in the chain needs, both in terms of information and in terms of their part of the patient's journey. Okay. So that was a comment from Norway.
Thank you very much. So there may be different approaches in different countries, and that's really important. So hopefully what I've set for you is the problem, really. The problem that we are reactive, need to be more proactive, and that we don't work as a system. I've introduced to you some of the tools that we've started to use and hopefully will be further developed as part of the programme. What we're going to do now is to go into more detail on the interventions at each microsystem level and some interactions between the microsystems, and then we'll have some discussion on that. I'm going to hand over to Anne for the first piece of the...
Thank you very much. I think it's important to explain a part of what John said before, that when we entered the Safer Clinical Systems work, there were already 2 organisations here in a single geographical area who were working with improvement quite deeply, and in the case of the hospital we were trying to build our own system for improvement called the Bolton Improving Care System, very much based on Toyota methods, as John said. But entering into the Health Foundation work, we didn't feel that it was a separate project, as it were. This isn't something about just sort of being interested in something on the side. What we absolutely wanted to do was take the learning and weave it into and make it a living, breathing part of what we're trying to establish as a daily way of working across patient pathways, right through from primary care hospital and back out again. There'll be many people in this room who have already worked with SBAR as one of the ways of standardising, and standard work is a key element of the Bolton Improving Care System, standardising the characteristics of essential communication about patients, especially at the interfaces and the handovers. So I guess a lot of people got to SBAR before we did, and we completely accept that we've got a long way to go. But we did find it useful standard work that it would follow, that handover would follow a particular framework, and we found out as well as we tried these things. Try-storming is one of the methods that we regularly use. That the T for teach back was as important as the other 4 elements, and that affirmation from the person receiving communication is as critical as framing the communication in the first place. So SBAR actually turned up. We got to grips with it a bit better through Safer Clinical Systems, but it actually began to manifest itself as part of the response to a number of issues that we began to use the tools to investigate more deeply as we went through the programme. So trying to understand what was happening at handover, both within the hospital and across pathways of care, manifested lots of rubbish, you would call it. I mean, all the way through this conference, no doubt, when you've listened to anybody who's based their improvement methodology on lean, you'll have heard the word waste. And the first impression of waste is kind of monetary waste or wasted time and wasted effort. But do not be under any illusion. Waste means harm. It means poor safety. It does mean harm by definition when you look at it in our clinical systems. So we understood through having used the tools and having engaged frontline teams exactly what a mess was out there. And we did begin to engage in more communication and more engagement of staff in the front line around the merits of SBAR, and particularly to tackle what we could see was happening with handovers. We looked for people who would be willing to try out and not get downhearted when it wasn't right first time, but to keep at it, which is another important principle of not treating things as a project, I suppose, but treating them as daily life. We used the gap analysis to try and understand what was driving the breakdowns that were very evident. And we identified the key waste using the methods that we've all become very familiar with. And as John said, the global trigger tool, as one way of identifying the harm and the waste in a system, brought up readmissions as the biggest indicator of harm in our routine monitoring. We focused in on the ward-based handovers in the hospital to begin with, because we were very aware from work that we were already doing in our high-volume urgent care pathways that we'd got issues, we'd got problems. We had poor clinical outcomes in some of our biggest high-volume urgent care pathways. And we already had teams working with this. I think as a hospital, we'd also come to the conclusion 2 or 3 years ago that when we really stood back and looked at how our hospital was organised, we began to understand that it wasn't organised around medical and surgical, or even around urgent and elective. What you could see when you looked at the highest level at the data about our activity, it divides along lines of fairly predictable, episodic, probably able to be managed through standard work, major processes. And for those types of patients, we understood, and we have understood through the experience of our own improvement work, that the more you can have that governed by standard work, that the drumbeat of that system works through standard work, the better flow you will get. And by flow, by definition, we mean a safer, better experience for patients. But the other group of patients at the highest level that we could see coming through our hospital were not as predictable. They had many more interdependencies. They had many more unexpected events that could happen during their episode or during their journey. And what we began to see for them was that the standard work that made them flow through the hospital was one decision flow. So one piece flow as a principle of good flow holds good. But in the case of these complex patients, the concept is translated as one decision flow. That makes patients flow through the hospital with higher quality, lower waste. And that we already had in our heads. So we applied our thinking about how do we clear the blockages of flow at handover by looking at ward-based handovers and A&E handovers, and we applied similar thinking to when we're crossing over boundaries, particularly out to the community, out of hours. We don't stand up here at all saying that we're a brilliant lean organisation, because what we see every time we go back to actually go and see what is happening out there, not what's on a report or not what's meant to be happening, is this kind of thing. And the most basic way of recording and representing what's happening in a pathway can be that very thing that creates the momentum and the discontent with what a mess it is. So on the left there's a handover diagram. I don't know if people have used these, but they are very visual and uncomfortable exercises where you map the communications in a single process between people who are described around the rim of the circle, and then you look at how many interactions there are to complete one task, maybe a discharge or an admission. And what this shows is it's a mess. There's a great scope for confusion and certainly a lot of waste. And I think what it also shows at is look at the nodes on that circle, because those are people. They are people whose daily lives are made up of something very stressful, quite complicated, and probably fixing things on the hoof regularly, and using lots of brown paper to map a process and actually to measure what's going on in the process is also quite a sobering experience, and I'm sure a lot of people here have seen that happen. We looked at the current state, obviously, having tried to understand what it looked like, and we decided to pilot our concept of what needed to improve around assisting flow around the respiratory pathway. There were good reasons for doing that. In Bolton, it is the highest, or breathing difficulties are the highest single reason for people presenting as urgent care cases. We had excess mortality, so our hospital standardised mortality was 118, and 21% of deaths in the whole of Bolton are attributable to respiratory disease. In the clinical teams in general, there was low morale, probably because they felt like they were being battered from all directions, and obviously their outcomes weren't great. They were as conscious as anybody else of not doing the good job they wanted to do. We had excess lengths of stay, and the readmission work that we'd done demonstrated that we had high readmission rates in that pathway as well. So taking the concepts that we'd got to grips with, we looked in detail about what was happening, and particularly around the flow and the discharge process. And the clinical team, not the trust, not the suits, not the analysts, the clinical team themselves, led by their own senior clinicians, absolutely designed what it would take, they thought, or at least they were willing to try it, to create that flow and that hand-on more smoothly in the respiratory pathway. And they came up with this concept of patient gateways, which had actually been tried tentatively in some other specialties, but they really embraced this and made it their own. And their solution to providing one decision flow was to alter the way the wards worked entirely, and indeed how the consultant job plans worked entirely, such that there's now regular, twice-a-day multidisciplinary decision making, with nobody leaving those decision making meetings around the visual boards about patients not knowing who does what next and who will be accountable for it sort of the next morning when it's reviewed. And all of that sounds like textbook, Toyota way stuff. But this is what textbook Toyota way stuff results in. This was the mortality trend on the HSMR for respiratory. And we started the work in Q2 2009. And it's continuing to fall. And the hospital had a keen interest in this. We are very, very dominated. The whole healthcare system across Bolton is very, very dominated by its urgent care demand. And I think John's description of the social factors might help you to understand that. And we know when it goes wrong, everything goes wrong. The elective care goes wrong, staff morale goes wrong, patient safety and experience goes wrong. And the costs certainly go wrong. This demonstrates how putting some order into the flow of patients through the use of the one decision flow and the handover reduced the chaos, the variation in the system around length of stay reduced, and overall the length of stay reduced for that high volume pathway. And these aren't the only indicators of what happened. Staff morale, by all objective measures, went on an upward path. The number of emergency scoops to high dependency and ICU reduced, and it was the right people applying the right method. And that's just an illustration, really, of how we try to weave in the tools from safer clinical systems. This is another example in a completely different setting, and one of the leads on the team that was involved in safe clinical systems happened to be an obstetrician, and he began to think through, so what would this mean for me? And he knew that one of his problems was the number of babies who were being admitted to neonatal care because of low APGAR scores, and he began to think through exactly in the same way with his team, supported by the learning, around what could be applied. So the aim really was to achieve a greater level of compliance with the objective measures of CTG monitoring, and to not only have more people understand what they were seeing on a CTG, but to respond appropriately and thereby to improve the outcomes of those babies. So we applied the methods, the things that we've heard about today, thinking seriously about standard work and decision making that I've just described exactly the same way in the respiratory pathway for a completely different group of patients. And understood pretty quickly what were the manifestations of the things that appeared not to be working. So there was inconsistent recognition of CTGs, no consistent way of escalating, and a baseline assessment of communication suggested it wasn't that bad, but even the staff at the front line themselves could see that it needed improvement. Added to that were all the classic things that you see in a hospital, certainly, and probably across other health settings as well. There were different machine types in the delivery suite, equipment wasn't where it was supposed to be, and it was non-standard. So having, in the doctor's definition, undertaken the differential diagnosis, we went on to look at what might be the treatments, using what we'd learned from other places, and particularly understanding what the human factors learning had given us. The main interventions that were introduced were the CTG checklist, so that every patient note has a record of and a guide to dealing with CTGs at regular intervals. Standard work, so the use of the sticker to indicate that the CTGs were being conducted as standard, and having guidance there and then at each place for no matter which member of staff it was that was carrying out the checks as to how to do it and what to escalate, and then the use of SBAR for the communication where things needed escalating. So how did we monitor the patient? This is monitoring the monitoring. We wanted to look at babies with low 5-minute APGAR scores. Due to hypoxia, babies will always have, there will be a number of babies that have low APGAR scores, but the ones that we felt we could most directly address were those with low APGAR due to hypoxia, and they are the ones who very often need resuscitation, and then they need time in the neonatal unit. And we wanted to have a look at what our emergency section rate would do as we changed our response to low APGARs, and we wanted to know what compliance there was with the new system. So having applied the diagnosis and then the understanding the treatment and gone round for an observation to see what needed changing as we progressed along our journey of learning, we found that we actually had achieved within about 6 or 7 months an 80% compliance with use of the stickers. And by February 2010, that was only a matter of weeks after this was introduced, there had been a marked reduction in babies going to the neonatal unit. You can see the flat line after the introduction. It actually peaked again in August. Now, significantly, August is the junior doctor changeover. And one of the things you should always learn in the healthcare system in England is never get admitted to a hospital at the beginning of August or February, for those very reasons. What this shows is that despite the fact that we were picking up babies and their care was better neonatally, we weren't overreacting with caesarean sections. So we were watching that as a control measure. And in fact, our neonatal unit admissions due to although the low APGAR scores didn't show a significant reduction, as this is showing, actually what was noticeably reduced were the number of admissions to neonatal units due to hypoxia. So that really encouraged that team to keep going for further levels of improvement. It's really only an illustration, as the respiratory one was, of how taking that learning and supporting a frontline team to apply it in their situation starts that new view of the world of these issues are arising because of processes, not because of errors at single points of contact. And I pay tribute to John Tomlinson, who was the obstetrician who led our Safer Clinical Systems team within the hospital grouping, and his colleagues who got to grips with their own issues in delivery suite in Bolton. All right, Johnson.
There are a whole series of other examples that we could use, and we may come back to some in a minute. One was around the A&E department, where we got the A&E department and the laboratory learning what each other's problems were, and you can see on this slide an illustration of, from that co-working at the meso level, an understanding of the interdependency and working together to solutions which had massive effects. We were measuring safety culture using new tools, and this is one particular tool in one of the urgent care areas, and we began to see some changes in culture, but measuring culture was an important component. This is another tool which was adapted from a hospital ward and then further adapted around understanding patient falls better for the Bolton community unit, and a number of changes resulted from understanding exactly when and where the accidents happened. As we move on the patient's journey, the patient will go into the skilled nursing facility and intermediate care, and there'd been work going on which was continued for actually a considerable number of months on medicine safety, both when the patient comes in, how that's administered, moving to electronic systems, enabling the patient to take the medication themselves, enabling administration charts for when they're being cared for at home by others or in other facilities, and discharge from that facility into general practice. And over that time, with the multiple interventions, there was a fall in significant medication incidents. When we started to look at then medication reconciliation when the patient had left that skilled nursing facility into primary care, we found that in 28% of cases there was a significant error that when we looked at it through audit that could well have affected them and may have caused the patient to be readmitted. So as an intervention, we're now looking at a pharmacist working with these very complex patients to try and reduce it. When we then went on to look at the final end in general practice, and this is one particular practice where we then started to map the processes around repeat prescribing, particularly focusing in on what happens when the patients come out of hospital or come out of another facility, even if the information is there and correct. And what we found was this very complex system of 33 steps, 10.5 hours of practice time, lots of communication. So really no system at all, a chaotic system, hardly surprising that errors were occurring. And so some redesign work took place, and this is being implemented now to a completely new system of repeat prescribing in that one particular practice, is now being tested and adapted in others. So I hope that what I've illustrated is that a number of interventions across this patient pathway, using a proactive approach and learning and spreading that across the system. We still feel we're very early on this journey, but we do feel that patient safety is more embedded across this particular patient journey. Now, because of time, and this is where we are so far with readmissions. Again, early stages, trends that look hopeful, but a lot further work to do and a lot more good practice to implement. Because of time, I'm going to move on to the lessons we've learnt, and then we'll get into some questions, and Anna and I will share the responses to those. So there were certainly some successes in terms of teams learning to work together, and this shift to a more proactive approach, and the approach of adapting and spreading. And we began to see a change in culture within teams. But there were some real challenges as well. Changing personnel meant that certain pieces of work got dropped. We didn't manage to institute the primary care trigger tool. Some of the timescales we gave ourselves were very unrealistic, and we were really challenged by measurement across the system in a consistent way. the understanding of the different cultures, both between the two organisations and between the clinical teams, took time. It took many, many months for us to understand those differences and actually work with them through that understanding. And we were unsuccessful in terms of good patient involvement. We've heard some good stuff around that at this meeting, but at this stage we didn't use that. So the overall schema that we developed in terms of safer clinical systems is that we feel there are a number of things which are important across the system that are illustrated on this slide, but there's a process that we need to take place in this proactive approach around diagnosis, quantifying the problem, making the system resilient and ready, and then measuring, continuous measurement of what's happening. The benefits for us so far are around working together, building some new expertise, learning from others, and of course we have some profile in the programme. But we do believe it really is the start of a new approach to patient safety. If there are some top tips that we'd like to share with you in terms of starting this journey on patient safety across the continuum, they're these. Firstly, define your system based on a patient journey. It might be urgent care, it might be something else. Get a leadership team across that continuum. Do the proactive risk assessment and develop interventions. We don't believe that incident reporting and walk-arounds on their own are enough to identify the issues. Understand the cultural differences between clinical teams and between organisations. But don't do it as a project. Embed it in your normal mechanisms, your normal improvement systems, your normal governance systems, otherwise, and report up to leadership in the normal way. So, we believe, and the Health Foundation, through this co-creating phase, working with us and other sites, believes that safer clinical systems is a new approach to patient safety, and we've shown you some of that. What's now going to happen is that a phase 2 of safer clinical systems is going to be launched on May the 6th, where they're looking for 8 teams from provider organisations in the UK that are working across interfaces to work particularly more on using the learning from this in a more systematic way, with a series of tools and interventions being used in those settings, looking particularly at handovers and patient medication, and creating learning interventions. And this is the final slide I want to show. This is what is designed for phase 2 of safer clinical systems. Describe a series of steps: the assessment and diagnosis phase, the testing and implementing phase, the developing resilience phase, and a lot of that is about culture and developing a safety culture within the teams and embedding it in your normal system, and that ongoing monitoring. And if you've developed a learning system, then further changes. But you see I've put on this slide the zoom in, zoom out approach, and this is about looking at it at the microsystem level, going back to see how it affects the whole patient journey, and then going back in to wherever. So this consistent micro, macro, zoom in, zoom out as you go through the assessment, the implementation, and then the continued learning. So because of time, I'm going to stop there. Sorry we haven't had more time for discussion. I think we've probably got about a minute or two to do that, and clearly we'll be hanging around for some informal discussion if you want it. Any points people want to raise? Any questions? Any challenges? Chris?
Sorry, I'll speak very loudly if there's a mic. I think it's really a question more for perhaps the Health Foundation, everybody pushing it. If the results are so good, why is it only going through another 8?
It won't. I mean, I think I want to emphasise we've had a co-creation stage. We've now got tools which have been developed. they need to be tested in the other 8, and this approach much more embedded than it is in us. In fact, all the 4 teams said, actually, we want to be in the next phase because we don't feel we've really tested these. And then when it goes from those 8, the plan is it's then spread very, very much more widely than that. Yeah, Kenny, thanks.
General paediatrician from the north of England. I was from the northeast of England. I was slightly surprised, given the macro nature of your investigation, that the 2 interventions you described were quite focused, and that just surprised me. I don't know whether you could. I mean, I guess the neonatal one was the one that's nearest to my practice, and I guess I expected interventions around neonatal unit admissions that were wider in
well, I think
context.
what we were trying to illustrate in the neonatal one was not specifically what happened in the neonatal unit, but the illustration that by working on urgent care, then there were lessons learnt which were directly applicable in another. And actually, the development of the teach-back with SBAR actually started when they were working in the neonatal unit and then was spread back into all the other gateway work that Anne's described. So, first thing is, I think, early in the journey. Second thing, the illustration was the sort of cross-learning that needs to go on in that. Anna, you might want to add something.
Yeah, sorry. Well, it was illustrative, and I suppose it was illustrative of the fact that when you've got a clinical leader in particular engaged in understanding more about the tools, you know, the FMEA and the create and detect, because he'd been very up close to it, then his appreciation of what was causing issues across the system, even though that was quite a small system, was a really good illustration of how you could apply the learning. Obviously, the respiratory example was applying that learning across a much bigger pathway, and how that would affect the outcomes in that pathway as well. So, no, they were just deliberately chosen as 2 examples. There were others as well.
We could have chosen a whole series of examples from across the pathway.
I'm Jesper from Denmark, and I think it's an interesting story, but I'm also concerned about this issue we are talking about, this conference between quality and costs.
Yeah.
So my question is, do you make business cases about, is it worthwhile? Because as I hear it, you invested a lot of time making analysis, and what's the benefits compared to the costs?
The business case will be if the readmission rate goes down, the medication harm goes down, and we can't put our hands on our heart at this stage in terms of that whole programme. I think the respiratory work, there's a very clear business case from that in terms of reduced length of stay.
Well, even that
you know how much time you're invested in this kind of improvement?
Well, none of it was new teams, or these are teams that were already working on quality and safety and improvement. There was no new investment here. These were teams already working on it that just started to use a more joined-up approach.
Yeah, and I suppose the counter-argument to that is how many hours do we spend in a committee room, you know, year after year, solving the same problems, apparently. And this is about doing it, you know, trying it, properly supported through a method, through a system, but then applying it and learning and improving it, which, well, I suppose you could say that time and effort spent doing it doesn't come free, but the rewards are huge, you know. I mean, not just in terms of patient experience, but in terms of the payback. I mean, those respiratory length of stay data described, you know, beds closed eventually, and the number of children not being admitted to the neonatal unit means that, you know, we are saving resources further down. I think there is a danger with improvement, that people try and put the improvement effort in one side of the scales and how much does it cost and all the rest of it. But my firm belief after years of what we've been doing, right and wrong, is that the directly measurable money out measures are there to be had. But there are many, many more indirect financial benefits that are just never quantified, because you're actually changing a whole system to act differently as you go on. There's a very good paper that the Health Foundation has sponsored on the business case for safety, for improvement.
So we'll have to stop there because of time. Apologise for those for the next session that we've gone over, but I hope you found it helpful. Look forward to continuing the discussion.